Hi, welcome back. Last time we met, we were discussing early stage disease and treatment in the adjuvant setting. Remember, early stage disease, relatively small tumors, little to no nodal involvement, surgery, adjuvant therapy. Locally advanced disease. Now all of a sudden we're dealing with larger tumors where we have more nodal involvement. So this is higher risk. And the disease is a little bit more concerning at this point. Also, since we're dealing with larger tumors, the likelihood of being able to perform a lumpectomy has been reduced. However, certain interventions, certain therapies can allow us to essentially convert something that's inoperable to operable. And that's this concept then of neoadjuvant therapy, right? So when we talk about locally advanced disease for breast cancer, we're largely referring to stage 2Bs and then stage 3 in terms of tumor size and nodal involvement. But this is still going to be M0, no metastases. All right. And again, too, here is the staging. So we're kind of drawing a line here all the way down through here. So this is sort of where you might lump in some locally advanced disease. And this is going to vary from patient to patient as well, sometimes as well. But nonetheless, the typical approach here might be to administer neoadjuvant treatment to essentially shrink the tumor. And ideally, we end up with something called a pathological complete response with neoadjuvant treatment. Then we can perform a surgical procedure. Maybe we can do a breast conserving procedure, a lumpectomy, or maybe we have to do a mastectomy at that point. Maybe something else happened and the lumpectomy just isn't feasible anymore. After the surgery and after the patient recovers, then we have to entertain this discussion on adjuvant treatment. What do we do, if anything at all, in the adjuvant setting? And all of this is going to depend on the patient, the patient's comorbidities, how well the patient can tolerate things, what's their performance status, and importantly, the tumor characteristics, just like we described in the early stage disease adjuvant setting. And keep in mind, if a patient receives, historically, if a patient receives a full course of neoadjuvant chemotherapy and they achieve a pathological complete response, they typically don't get any additional chemo in the adjuvant setting. Okay? This is sort of like the holy grail when it comes to chemotherapy, neoadjuvant chemotherapy. Getting that pathological complete response carries with it a very, very good prognosis. All right. So what do we do? Well, the goal of neoadjuvant therapy is to essentially induce a tumor response before any surgical procedure is performed, and it will, if you induce a tumor response, it will enable some type of breast conserving procedure. And what we do know, though, is results in terms of long-term distant-free, disease-free survival and overall survival are essentially comparable. When a patient goes right to the OR and with adjuvant treatment versus neoadjuvant treatment and then the surgery. So there's nothing statistically different about going to the OR and having a mastectomy followed by adjuvant therapy as compared to neoadjuvant treatment and then surgery. They're comparable. Regardless, we need to know what the hormone receptor status is of the cancer. Is it hormone receptor positive? Is it HER2 positive, or is it triple negative? With triple negative, it's kind of intuitive at this point. We are going to use as aggressive a regimen as we can. And nowadays, we've incorporated immunotherapy with chemotherapy. So we can use PD-L1 blockers with chemotherapy in the triple negative setting. And I'll show you some study data that supports that approach. If the patient has a HER2 positive breast cancer, This is where we're going to use HER2-directed therapy in the form of trastuzumab with or without pertuzumab, added to chemotherapy in the neoadjuvant setting. And then for the hormone receptor positive cancers that are experiencing disease because of the presence of estrogen receptors, for example, it's intuitive to think that we would use endocrine therapy in this setting, but recall we don't use endocrine therapy up front. We prefer to use chemotherapy because chemotherapy is going to induce a much faster response in that patient. Endocrine therapy, endocrine neoadjuvant therapy has a role, but only in select patients, patients that can't tolerate chemotherapy, patients that frankly are going to refuse chemotherapy in the neoadjuvant setting. But otherwise, we want to use chemo to induce the tumor response. So for hormone receptor positive disease, not surprising, you're going to see this ACT regimen come up again. There's many options, but the preferred regimen based on the data and based on the response that gets generated from using dose-dense ACT, it's the preferred regimen. Recall, this is a 14-day cycle. Every 2 weeks, the patient is going to get doxorubicin and cyclophosphamide on day 1 for 4 cycles. After we finish that 4th cycle, we will ultimately begin an intense round of taxane treatment. We're going to give paclitaxel, 175 milligrams per meter square, every 2 weeks for 4 cycles. That comprises then the neoadjuvant regimen. And then after the patient gets done with their neoadjuvant regimen, we go into the OR. And they will open the patient's lesion up. They'll look for any residual tumor, remove it, and then make a decision on adjuvant therapy. Dose dense just basically refers to the pace or the frequency at which the patient is getting this regimen. So every 2 weeks is dose dense treatment. And you can't do this with everybody, but in the right patient, you can approach it in a dose dense fashion. But keep in mind, you do need to use growth factor support. Okay, we're going to be giving these patients filgrastim or pegfilgrastim to stimulate bone marrow so they don't get neutropenic and have a compromised immune system during the course of this dose-dense treatment. Other regimens, we can opt for the dose-dense AC followed by weekly taxane. It just takes a little bit longer. Instead of getting this done in 8 cycles, it gets pushed out a little bit longer. It's going to take a little bit more time. And then there's the TC regimen that we made mention of before. This omits the anthracycline. So the patient's going to get docetaxel and cyclophosphamide every 21 days for 4 cycles. Okay, so those are some chemotherapy regimens that can be used in the neoadjuvant setting for hormone receptor positive breast cancer. We do neoadjuvant treatment, surgery, and then adjuvant treatment. These are hormone receptor positive cancers. So what do you think is going to be given in the adjuvant setting? Endocrine therapy. What endocrine therapy? You guessed it. Kind of depends on menopausal status. But I can guarantee you too, if you had a premenopausal patient that went through neoadjuvant treatment with one of these intense cycles, that chemotherapy is going to reduce her ovarian function such that she's going to respond like a postmenopausal patient. Right? Locally advanced HER2 positive breast cancer. What do you suppose we use in the neoadjuvant setting here? What's the neoadjuvant treatment for this type of breast cancer? Well, we are going to combine trastuzumab with chemotherapy, and then we're going to consider using pertuzumab as well. And there's a couple different regimens that have been investigated over the years that have shown to be very, very efficacious in the neoadjuvant setting. Pertuzumab itself is typically reserved for patients who have a higher risk cancer. And when I say higher risk here, if the tumor itself, the primary, is larger than 2 centimeters, or if the patient has node positive disease, that's when pertuzumab is added on. And since we're talking about locally advanced disease, you're more than likely going to see somebody with a large tumor and or nodal involvement, right? There's been a variety of studies, again, that have been conducted over the years that have demonstrated this regimen, TCHP, right? TCHP as one of the more potent neoadjuvant regimens we can give a patient to induce a response prior to surgery. TCHP stands for Taxotere, which is docetaxel, a taxane, carboplatin, right, a platinum derivative with a target AUC of 6. That's the dose. AUC is 6. And then the H stands for Herceptin, which is trastuzumab. And then the P stands for Perjeta, which is the trade name for pertuzumab. Right? This is TCHP. I'm not a big fan of abbreviations, but this is what's done in the industry. This is how they talk in the cancer centers with regard to breast cancer and all the other cancers for that matter. So we give this regimen every 3 weeks and we target for 6 cycles. We want to try and get this patient 6 cycles of this regimen. Then they go to surgery, and the surgeon is going to investigate the area where the lesion was or is. They're going to look for residual disease and then go from there. One other regimen is the TCH regimen, and I think we mentioned this early on. TCH is, again, the taxane, Taxotere, with carboplatin at the same dose, the same target, AUC of 6, and just trastuzumab this time. No pertuzumab. Same frequency though. Q3 weeks times 6 cycles is the goal. Pertuzumab, again, add pertuzumab, you add diarrhea. All right, that's one of the things that was noted in the trials. For this particular study. It's either the Neosphere, I think it was the Neosphere study that investigated TCHP and adding pertuzumab in the neoadjuvant setting. Diarrhea was one of the biggest complaints that patients had relative to the comparator group. Okay. And then when you look at the guidelines, again, too, we're talking about HER2 positive disease, preoperative, which is equivalent to saying neoadjuvant here. TCH, TCHP. All right. Now, I want to point this particular area of the guidelines out to you. If residual disease after preoperative therapy is noted, meaning the patient didn't achieve a pathological complete response with TCH or TCHP, you could add or you could use this drug called atotrastuzumab emtansine, or Kadcyla is the trade name, alone in the adjuvant setting. All right, in the adjuvant setting. And then one other point I want to make again. If it was hormone receptor positive in the adjuvant setting, we would use endocrine therapy. If it's HER2 positive, we use the antibodies to complete 1 year of therapy. That holds true in both the early stage disease setting and the locally advanced setting. 1 year of anti-HER2 antibody therapy. If it was just trastuzumab, we would do trastuzumab for a year. If it was trastuzumab plus pertuzumab, we would try and do both for a year. Tough to tolerate, hard to get a patient through that, but you try. If they can't tolerate both, you can go down to just trastuzumab. Okay. So in a nutshell, that's locally advanced disease that's HER2 positive. What about locally advanced triple negative breast cancer? This is an area of excitement in the breast cancer setting. A lot of studies have been done to try and optimize therapy for patients with triple negative disease. And it's not uncommon to find a patient with locally advanced triple negative disease. Now, historically, what we used to do is we would give them as an aggressive chemotherapy regimen at the onset as possible. Dose dense ACT, for example. That's what we would use if they had triple negative breast cancer in the neoadjuvant setting. If they weren't a candidate for dose dense ACT, maybe they had some pre-existing cardiac condition, maybe we would just do TC and drop the anthracycline. One other interesting area for individuals with triple negative breast cancer is an investigational trial. Right? There's a lot of centers around the country that are actively recruiting patients for an investigational trial looking at novel approaches to treating triple negative breast cancer. And it's actually really good care because you are either going to get the standard of care for your disease or you're going to get the standard of care plus something else to see if that something else adds to the standard of care or might even replace then the standard of care at some point. And a good example of that is the Keynote 522 study. Right, so Keynote 522 was initiated a couple years ago, and this study wanted to investigate the role of immune checkpoint inhibitor therapy in combination with chemotherapy in both the neoadjuvant and then the adjuvant setting for patients with triple negative disease. So patients who had high risk stage 2 or stage 3 triple negative breast cancer were enrolled in the study. Some of them got standard of care chemo as neoadjuvant therapy. Some of them received neoadjuvant chemotherapy in combination with pembrolizumab, Keytruda, in the neoadjuvant setting, and then they got additional pembrolizumab in the adjuvant setting. Right, so they really wanted to ask the question, does pembrolizumab do anything? Does it add anything to chemotherapy in the neoadjuvant setting? And then does it prolong overall survival or disease-free survival or even progression-free survival, in the adjuvant setting? Here is the conclusion from the initial study. Among patients with early triple negative breast cancer, the percentage with a pathological complete response, right, no evidence of tumor at the end of therapy, was significantly higher among those who received pembrolizumab plus neoadjuvant chemo versus those who received placebo plus neoadjuvant chemo. Right? So based on the study results, this is a positive study. It helped to induce a significantly higher percentage of pathological complete responses. And you can see here what the regimen involved. This is a pretty robust regimen. Right? In the neoadjuvant setting, the patient is getting the immune checkpoint inhibitor, pembrolizumab, and then they're getting a taxane plus a platinum, and then that's followed by 4 cycles. Then they get pembrolizumab plus an anthracycline and a nitrogen mustard for an additional 4 cycles. This is the point then where they would go to surgery. And then after surgery, they would continue their treatment with just the pembrolizumab alone, the PD-L1 monoclonal antibody. And they do that every 3 weeks for 9 cycles. right? So immune checkpoint inhibitor plus a chemo regimen, followed by immune checkpoint inhibitor plus additional chemotherapy, then surgery, and then more immune checkpoint inhibitor. Well, what we ended up figuring out here is, again, the pathological complete response was significantly higher. So this has made its way into the guidelines, and this is being used in your breast cancer settings. Okay. Locally advanced disease, you have surgery, and then you have to make, again, the decision on adjuvant therapy. So is the surgical procedure that's done, is it a breast conserving procedure, i.e. a lumpectomy, or is it a mastectomy, right? We do that after neoadjuvant treatment. And then for HER2 positive disease, again, 52 weeks or 1 year of monoclonal antibody. If it's hormone receptor positive, again, endocrine therapy. Usually it's going to end up being an aromatase inhibitor or tamoxifen. And then for triple negative breast cancer, based on that keynote study, adjuvant pembrolizumab, it improves survival. Right. And we're going to continue to learn more and more about how to take care of these patients with triple negative disease as more studies come out, looking at different PD-1 interference. If you look at the guidelines will make recommendation on the use of capecitabine or Xeloda in the adjuvant setting if a pathological complete response wasn't achieved as well. But my feeling is, in talking with some of the local oncologist, Dr. Thomas in particular, the use of neoadjuvant and then adjuvant pembrolizumab is going to become very pervasive. Okay. All right. So to summarize, locally advanced disease. What is the treatment approach to locally advanced disease? Neoadjuvant treatment. Why do we give neoadjuvant treatment? Shrink the tumor. Then we can do a breast conserving surgery, and then we do adjuvant treatment. Okay. What neoadjuvant treatment? Well, if it's hormone receptor positive, we want to use what? Chemo. A good example is dose-dense ACT. Okay. A is anthracycline, doxorubicin, plus cyclophosphamide, Q2 weeks times 4. Then we would do what? Come on, hold still. Taxane, like paclitaxel, Q2 weeks times 4, and then go to surgery. That's the neoadjuvant approach for hormone receptor positive. For HER2 positive, TCHP or TCH. Okay. And that's taxane, like Taxotere, which is docetaxel, plus carbo, plus Herceptin, plus Perjeta. All right. That's TCHP. TCH is the same thing without the Perjeta. So we did hormone receptor positive. We have HER2 positive. If we have triple negative breast cancer, one option, again, is dose-dense ACT. Right? Another option might be just TC. Right? Individuals who can't tolerate, say, an anthracycline. Likewise, we can use the Keynote 522 regimen, where they use immune checkpoint inhibitor plus taxane and platinum And then we do immune checkpoint inhibitor plus anthracycline and cyclophosphamide. Okay. So this is all in the neoadjuvant setting. And then keep in mind, once we get done with neoadjuvant treatment and the patient goes to surgery, we still have to consider adjuvant treatment for hormone receptor positive. What is it? Endocrine treatment in the form of an aromatase inhibitor or tamoxifen. This is evolving as well, premenopause. If you're premenopausal, are you a candidate for an aromatase inhibitor? Based on what we talked about in the early stage setting, you need to suppress ovarian function before you give an aromatase inhibitor. The chemotherapy that was administered in the neoadjuvant setting should have addressed ovarian function. And there are studies going on right now to try and figure out the best way to assess ovarian function after chemotherapy has been administered. There's something called an anti-Mullerian protein or antigen that they're looking at as a marker of ovarian function, but that hasn't made its way into any guidelines yet. So you want to make sure that the ovaries are shut down in your premenopausal patient before using an aromatase inhibitor, and the chemotherapy should have done that. HER2 positive disease, we do 1 year of monoclonal antibody, okay? Trastuzumab or trastuzumab plus pertuzumab. Triple negative breast cancer, again, evolving field. For triple negative breast cancer, if you got dose dense ACT and then went to surgery, you would typically then just do surveillance afterwards. If you do the keynote regimen, you get immune checkpoint inhibitor plus chemo, and then immune checkpoint inhibitor plus a different type of chemo in the neoadjuvant setting, and then immune checkpoint inhibitor in the adjuvant setting. So you'd get 9 cycles of pembrolizumab. There is some data out there, though, that has supported the use of PARP inhibitors in the adjuvant setting as well for triple negative disease. And I believe those are relegated to individuals who have a germline BRCA mutation. But let me clarify that for you because these change probably 5, 6, 7 times a year. Okay. But in a nutshell, if you can wrap your head around this, right, you're going to be in really good shape. I think the hardest part is just making sure you understand how things flow. If it's hormone receptor positive, we do what? If it's HER2 positive, we do what? If it's triple negative, we do what? And that's what we're going to continue to just reiterate over and over and over. Okay. All right. When we come back, we're going to start trying to tackle metastatic disease or stage 4 disease. We will talk to you guys soon. Bye-bye.